I am so excited to be here. I'm sharing the stage, the virtual stage, with some of my closest friends and colleagues. And there's just something so special about being part of an event in Alberta. We have some pretty strong Alberta pain pride going on right now, and so many exciting things that are aligning. So I'm just really thrilled and honored to be part of this event with some amazing women in science and medicine. So I think that Katie and Katie just beautifully set the stage for why pediatric pain matters, but also for this topic. And Katie, I just want to say, I cry every time I hear your lived experience. I've heard you speak before, and I'm just blown away by your bravery. We have so much to learn from your resilience and your experience. So thank you so much. I usually start with a story, actually an email that I received from a mother who was taking part in one of my research studies, who was really annoyed by filling out all these questionnaires. And she sent me a long email, really kind of sharing her frustration around, how it's not just about pain. Pain is not the only thing that has robbed, her and her daughters from the life that they wanted. It's really this broader context of mental health. And that email really changed my program of research. And it was around that time, I'm really inspired by people like Katie Burney, by Christine Chambers, by Jen Stinson, seeing their amazing work in terms of partnering with people with lived experience. And this is a train that I'm hopping on, and I really believe in the power. So I'm proud to say that I work closely with a person with lived experience, actually several on many of my projects. And this one is with my good friend, Janice Sumpton. So I don't need to preach to the choir, but maybe I do, because sometimes I'm even at big scientific review panels and we're having lunch and people turn to me and say, chronic pain is a thing in kids. So we can't assume that everyone knows the scope of this problem. And Chris Eccleston and Jackie Clinch once referred to this as a modern public health disaster. We know that about 1 in 4 or 1 in 5 children and adolescents experience chronic pain. And these are headaches, stomach aches, musculoskeletal pain. And often this pain didn't arise from an injury. Oftentimes the pain spontaneously emerges and is a problem in and of itself. We know now from the work of Tanya Palermo and Niels Groenewald that this is a very costly problem, estimated to cost about $19 billion in US dollars a year. And it really does affect all aspects of development, as Katie so poignantly explained. And what's really interesting is in the last 10 years or so, or less than that, we're starting to get really important longitudinal data to really follow these kids into adulthood and see what happens and see the long-term impact of chronic pain. And this is the work of Lynn Walker and colleagues out of the US, where she followed adolescents who had chronic abdominal pain. And she followed them into adulthood. And she found that basically up to 2/3 of these kids reported having pain and chronic pain into adulthood. And what really blew me away was the fact that even if the pain resolved, for many and not all, and I just want to give a spoiler, I'm going to end on a very resilient note, but we get there. But she found that even if the pain resolves, these kids are at higher risk of developing mental health disorders and issues into adulthood, issues like anxiety and depression. And we showed a few years ago, using large representative data across the US, that chronic pain in adolescents is a risk factor for the development of a lifelong course of PTSD, anxiety, and depression. Now, the field really focused a lot more when I was on postdoc. I studied children's memory for pain, so really interested in memories and distressing memories and how they develop. And I remember talking to my great mentor, Tanya Palermo, about what I was going to do next. And she said, what about PTSD, right? Like this, and we all know what PTSD is, that re-experiencing, it's bad things happening that lead to re-experiencing intrusive memories, avoidance, hypervigilance, alterations in cognition and mood. And so we started a study. This was in Seattle, but I'm happy to present Alberta data next. We basically followed a group of about 100 kids who had chronic pain and 100 kids who didn't have chronic pain and their parents. And we gave them some really kind of psychometrically sound questionnaires of PTSD and pain. And we were blown away by the differences. You can see here that children who had chronic pain had significantly higher levels of PTSD symptoms than children without chronic pain. And in fact, in this sample, almost a third of the kids met clinical cutoff for a diagnosis of PTSD. Parents also of kids with chronic pain were also reporting much higher levels of PTSD than parents of kids who didn't have chronic pain. You can see 16% of the parents met diagnostic criteria as compared to 0% of the kids without chronic pain. So this is also a parental sort of issue as well. But I found really interesting, when I always thought about PTSD and pain, I kind of imagined like, you know, a war veteran, someone who was away, who experienced, you know, horrific trauma that may have involved a painful injury. And so I could see how the trauma and the pain would be connected. But this was a group of kids with idiopathic or primary pain disorders, often that did not arise from an injury. And when we asked them, what was your worst event? So the event that they rate their PTSD symptoms on, you can see that, you know, very few of them endorsed that it had anything to do with their pain or was caused, you know, their worst event was their pain. Often they talked about death, hospitalizations or medical trauma, which is a huge problem. But you can see the range of traumatic events. And this also held for the parents. So it raised this really interesting question. Might early life trauma or traumatic events be a trigger for the development of chronic pain or the worsening of chronic pain? Or as in, you know, in Katie's experience, you know, she had developed pain and then subsequently had experienced a trauma. And the great thinkers in the field, in the adult world, Gord Asmundson, Joel Katz, some wonderful Canadians, and good colleagues and mentors, had really explained sort of factors, cognitive, affective factors that may serve to maintain PTSD and maintain pain. And so together with our colleagues, we kind of put our heads together before we gathered the evidence to try to understand, why do these two problems that may be independent co-occur? What's going on there? What are the mechanisms? So together with Amy Hawley, Tanya Palermo, and Anna Wilson, we proposed this mutual maintenance model where we really talked about similar factors to the adult models, things like memory biases, attentional biases, hyperarousal, and sleep disturbances. These are factors that people with chronic pain experience, but also people with PTSD experience. So maybe those shared factors are serving to maintain both conditions. We also know that parents, you can't study kids without studying parents, right? Parents have a huge influence. What about parents' own trauma? What about the ways that they're parenting and responding to threat, and how pain may be perceived as a threat that may serve to, from a social learning perspective, maintain both conditions. And then trauma and pain affect the developing brain. And we think that there are shared brain regions that are involved as well that serve to maintain these two conditions. Dr. Jillian Vanal, who works closely with us, another Alberta children's researcher, University of Calgary researcher, led this model that really expanded the mutual maintenance model to also understand the neurobiology. What about parents' own chronic pain, their own PTSD? What are the genetic or epigenetic factors that may also underlie this? So this was really work that really set the stage for the empirical data that I'm going to share with you. And I'm really excited because some of this data I've never presented before. And so here we go. We embarked with funding from the Chronic Pain Network, an amazing a network across Canada, joining chronic pain researchers, but also people with lived experience. This was my first foray into patient partnership. And with funding from them and the Alberta Children's Research Institute, we were able to launch this study, which we called the PATH study. And what we were doing basically was trying to understand, why does chronic pain and trauma and mental health co-occur? What are all of those factors that we had thought about in those models that may be serving to maintain this? It is a beast of a study. My REB is telling me it's not a study anymore. It's a program. So I, for the purposes of time and parsimony, I'm going to focus on just some particular aspects of this. But you can see that we have about 200 kids that come into the Viradel program. We have a few kids from Sick Kids as well as the IWK in Halifax. And they are coming into the tertiary level chronic pain program. At the time that they come in, they do diagnostic interviews to look at their anxiety, depressive, and PTSD symptoms. And then we do detailed daily assessment of their mood, their pain, their parents' parenting and how they're responding to pain. We also look at their sleep-wake patterns. We take saliva, so we look at epigenetic expression, gene expression, and we do everything from psychophysical testing, et cetera. And then we follow them up 3 months later to look at their mental health and pain again, to really understand how might these factors be underlying trauma and pain over time, and who's getting better and who's not. So, you know, diagnostic interviews are really a conservative estimate of whether or not a kid meets diagnostic criteria for a mental health disorder. And so you can see here that there's quite a range in terms of internalizing mental health, but you can see the prevalence is pretty low. But I want to caution against diagnostic interviews. They're wonderful, they're gold standard, but sub-threshold symptoms of anxiety, PTSD, depression are really meaningful and related to outcome. And so we don't just focus on, you know, the high elevated symptoms. We're also looking at kids who have sub-threshold symptoms because, you know, we're really interested in risk and preventing an exacerbation. So in our studies, we're really focused on symptom elevations. And when you look at whether their mental health is changing over the course of 3 months, it's not. So those blue bars are telling you that kids who met criteria at baseline are still meeting criteria at 3 months. We do a great job at treating pain. And the kids who are lucky enough to access care, you saw that this was one of the top 10 priorities. This is a problem. Most kids who have chronic pain don't access care, but the pain programs do a great job of the few kids that do. But our treatments to date, there are a few exceptions to this in terms of researchers who are really trying to target, you know, mental health of kids and parents, but really our pain treatments are focused on pain, right? So I'm not sure if this is super surprising, but it's important. This was a paper that was published in Pain a few months ago by my amazing graduate student, Maria Pavlova. And she basically showed that kids who had higher pain interference, so pain was getting in the way of their life, not surprisingly, they were more likely to have greater pain interference over time. But what was really interesting is even when you controlled for that, if kids came into the pain program with high levels of PTSD symptoms, their pain was getting worse over time. And this is important because trauma is not something many people feel comfortable assessing, and that's a whole other controversial talk, and I'm happy to engage with anyone who wants to. But this study really showed that like these symptoms are important for outcome. And I'm not sure how many of our pain treatments yet are really adequately addressing trauma. We were also interested in adverse childhood experiences, or otherwise known as ACEs, which I'll refer to throughout this talk. ACEs refer to a series of experiences, 10 experiences that occur before the age of 18. These include mental illness in the family, so household challenges, an incarcerated parent, a parent that engaged in a lot of substance use and abuse, observing family violence, and divorce, actually. But also there are other categories of ACEs that refer to maltreatment. And these would be things like physical and emotional neglect and sexual and physical abuse. And in a famous study by Folletti and colleagues in the late 90s out of California, they followed about over almost 14,000 individuals who had received a medical evaluation at an HMO, Kaiser Permanente, and sent them a questionnaire just asking, have you experienced any of these 10 experiences, adverse childhood experiences? And it was amazing. They found that, people that had experienced 4 or more ACEs, were reporting a 2 to 4-fold increase in, life-threatening physical conditions in addition to mental health conditions. Everything from cancer to heart disease to skeletal fractures to lung disease. And not surprisingly, since ACEs has been linked to chronic pain development, it's basically linked to everything that you can imagine. And so we were really interested in this because there were some new studies coming out really linking sexual abuse to the onset of, in childhood, to the onset of pain, et cetera. But really there hadn't been a lot of work on ACEs in the pediatric population, with the exception of 1 or 2 studies by Sarah Nelson, a close colleague. So in our PATH study, you can see here, when we asked youth about their adverse childhood experiences, you can see the prevalence here. So about, a quarter were reporting that someone in their household had a mental illness. 1 in 5 said that their parents had been divorced or separated. And you can see the rates of emotional abuse, physical violence, physical abuse. Now, I don't want to overstate a doom and gloom story. This is a high prevalence. It's shocking. At the same time, the majority of the kids that we are seeing had not experienced maltreatment. But still, I'll get to the nuance of the resilience message later. But what's important is, there was a dose response relationship. So kids that had experienced 3 or more ACEs were more likely to have lower quality of life over time. So this is longitudinal, looking at ACEs at baseline and outcome at 3 months. They were also more likely to have higher symptoms of major depressive disorder if you had more ACEs. And they were also more likely to have higher symptoms of PTSD. So showing that trauma, again, is meaningfully related to outcome. Now, I hope I've set the stage for the fact that trauma is a thing. It is related. I mean, I'm focusing on chronic pain now, but it's important to keep in mind that it's related to all kinds of child health and adult health problems. So we wanted to really understand, okay, we can assess this. We know it's related to outcome, but what are some of the key reasons why this occurs? Because if we can understand especially modifiable mechanisms, maybe we can do something about this and start, altering our treatments to really tailor and enhance outcomes for kids who have these co-occurring symptoms. So really inspired by, again, my mentor, Tanya Palermo, a wonderful person, a wonderful scientist who really has led the field of pediatric pain in terms of understanding sleep disturbances. We really focused in on, how these kids were sleeping and what role that may play. I found this really compelling article about insomnia. And I just put that up there to kind of emphasize. And if anyone has struggled with insomnia, I do. It can wreak havoc on your mental health, right? And so this is a key factor, we think, that's not just related to pain, and there's compelling evidence that it is, but also related to PTSD and the co-occurrence of trauma and pain. And we have a problem as a society. We have a sleep-deprived nation of teenagers. And this is really not trivial. The period of adolescence has been called the perfect storm for sleep problems. And the reason is that there are physiological changes happening at that developmental period, as well as social changes. I'm showing you my phone because we have also social issues that interfere with sleep. But there are circadian phase delays. There's a slow rise of sleep pressure, which makes kids want to physiologically go to bed later. And yet, as a society, we're making them get up way too early to go to school. And then there are a host of social factors that make this the perfect storm for sleep deprivation. And this is important because you can see here that in adolescence, at that period, which we know is when we see the real spike in numbers of pediatric chronic pain, you see that sleep duration decreases almost an hour and a half per night. To put that in context, there's some experimental research showing that even a half hour of sleep deprivation in kids can lead to emotional and cognitive difficulties. So together with my colleagues, Rochelle Machazik, who used to be in Calgary, who's now at Monash University in Melbourne, Australia, we started thinking about the role of sleep and pain in kids. And the bottom line is, if you look at a sleep-deprived brain, or the brain of a sleep-deprived child or person or animal, and you look at the brains of a person or an animal, a child or an adult who has chronic pain, there are shared brain regions that are involved. So there's something neurobiologically that links, the sleep and pain connection. And there's a lot of compelling epidemiological research showing that even sleep problems in young children, I'm talking 4, 5, 6-year-olds and young prepubescent kids, that's been shown to be a risk factor for chronic pain in adolescents. Interestingly, you see the same things when you look at mental health. That early sleep problems are a risk factor for the development of mental health issues as well. And through microlongitudinal studies, and there's a whole body of literature from our basic science colleagues showing that while sleep and pain co-occur, right, and poor sleep drives bad worsening pain, and worse pain makes it harder to go to sleep and get good sleep. There's really evidence now that sleep is a stronger driver of pain problems than vice versa. And so this was from the pain paper that we published, Maria Pavlova led. And you can see here that, as I showed before, kids who came into the program with more pain interference, their pain interference was getting worse over time. And a reason for that, one important reason, was their sleep was disturbed. We see the same things with PTSD and pain. That co-occurrence, that link over time was in part explained by the fact that these kids had insomnia and poor sleep quality, difficulties falling and staying asleep. And so this is really showing that we have two factors here that in our treatments, I hope we're assessing, but maybe we can improve the efficacy of our treatments, particularly for kids who are struggling with these co-occurring, trauma and pain issues by targeting trauma, but also targeting sleep. I just want to share, the other part of this program. I'm a psychologist, so I'm really fascinated by emotions and things that I can change through psychological interventions that can be so powerful. But we really wanted to also look at the shared neurobiology. What are the mechanisms? What are the potential biomarkers that could be identified for these problems? So Rochelle and her student, Sabrina Sahlberg, did a study to understand the role of early life trauma in the development of pain in the later adolescent rodent. So this was using rats. And basically at birth, they had two groups of rats. One group that were, experiencing early life trauma or adversity. So they were separated from their mums versus animals who were just reared normally. And then as those animals grew up, the only difference between them was either they had maternal trauma or not. They then assessed their anxiety, their pain, and around the stage of adolescence that would correspond to adolescence, they all had a surgery and were sleep deprived, actually. And then we could look at their brains and look at epigenetic markers that may underlie this early life trauma and pain connection. And a long story short, I'm happy to share the paper that, in the animals that had the early life trauma, when they grew up, they were more likely to show greater anxiety. They were more likely to show increased pain sensitivity. But what was really exciting was that we could identify particular epigenetic changes that underlied that relation. So we saw an increased expression of the 𝐒𝐂𝐂𝐑𝐈𝐁𝐄 receptor. We saw an increased expression of 𝐂𝐂𝐑𝐈𝐁, in both the prefrontal cortex and the amygdala. And what's really exciting now is that from the saliva that we're gathering, collecting from our PATH participants, we're actually seeing similar relations between similar epigenetic factors and ACEs and pain. So what this tells us, and it's preliminary, is that some of the same markers we're seeing in our animal models, we're seeing in our human participants, really kind of speaking to the importance and the power of these translational investigations, and also to make reviewers relax that we can use saliva and not blood draws. I'm sure Samina and Katie will be happy there, to collect this important information. So the last part of my talk, and I'm timing myself, Nives, don't worry, I won't go over. I won't be that person. Is really in the title, you could see that I said trauma and pain, an intergenerational problem. And so, what we found a couple of years ago, we decided to give parents a pain questionnaire to ask about their pain history. And we found that 50% of parents of the kids in our program, our pain programs, had chronic pain themselves. And in certain pain populations like migraine, we see an even higher percentage, 70% of parents who have chronic pain will have kids with chronic pain. So there is a connection here. And we got really interested in maybe how ACEs or early life trauma could get under the skin to lead to epigenetic and behavioral changes to then influence a child. Might early life trauma be one reason for the cascade of pain, in addition to just pain going across generations? And we do see in a robust literature that parental ACEs are linked to more developmental concerns, poorer health, greater mental health issues in children. So we wanted to see if this had any role in pain. So this is a paper that just got accepted in Pain Reports by Jamie Beveridge. All of this ACEs work is really led by her, and she's a brilliant graduate student. Look at the rates of ACEs in these parents. 37% report having a parent who had a mental illness. A third of them, had their parents got divorced. So you can see this here, pretty high numbers and higher than the original Folletti study. And the bottom line is, and this data has not been published yet, we see that parents of kids with chronic pain, higher numbers of ACEs in the parents were linked to parents themselves having a chronic pain problem. But what was really interesting and surprising, this is the cliffhanger, we did not see a developmental cascade. So while parental ACEs is related to a higher risk of parents themselves having chronic pain, we do not see that influencing the child's pain outcomes. So perhaps parental ACEs may be linked to the development of chronic pain or not. But what I think here, this is when I'm really happy to have null findings. Maybe this is speaking to resilience. And this, I think, I want to end on a positive note for one reason. That is going to make you remember my talk in a more positive way, that there's science behind that. But there's a positive message here. There has been research showing that positive childhood experiences can buffer against the effects of things like abuse and neglect on adult outcomes. And this is a really cool study. This is what I'm talking about, 7 types of things that are really protective that we can put in place for kids. The ability to talk with your family about feelings. Feeling that your family was supportive in difficult times. Enjoying community traditions. Feeling a sense of belonging in high school. Having at least 2 non-parents that genuinely care about you. Feeling supported by friends. And feeling safe and protected. These are things that we can put in place. And I get chills every time I think about this research. But in this study, they basically found, and this was a large study of about, over 6,000 adults, when they reported on their ACEs from childhood, when they reported on positive childhood experiences, they found that those positive childhood experiences buffered against the effects of ACEs. So putting more of those positive childhood experiences in place actually led to less depression, better mental health, and more social support. And when I think about people with lived experience in our studies and people with lived experience that I know, they're some of the most resilient people, caring. You talk about feeling cared for in your household. And so many of these things are in place. And I think this is speaking to some real resilience that we see. And it's a real positive message. So I'm going to end by saying, what can we do? Should we ask about trauma? Maybe. I think PTSD symptoms, very important to ask about because they are really explaining why some kids are getting better or not over time. We have interventions in 4 to 6 sessions and of cognitive behavioral therapy for insomnia. We can actually decrease insomnia. And I really, it's not just my soapbox, but I really think that if a child comes in with insomnia, we should be treating that right out the gate because that's going to make mental health and pain better. And maybe we can get more traction with our pain treatments. And Tanya Palermo, again, is really leading the trial work in this area. And finally, to plug Dr. Katie Burney, we are combining forces now, inspired by some of this work that Tanya did, looking at interventions to address parental distress. Katie is planning on leading, and we're going to be piloting this in the winter, a study where she's going to be using acceptance commitment therapy to address parents of kids with chronic pain who have chronic pain themselves to address their mental health and pain. So we'll be concurrently treating children with, cognitive behavior therapy, but also Katie will be leading interventions to address parental mental and physical health, which I'm so excited about. So I just want to end by saying thank you to all of you for inviting me and to my amazing graduate students who really, I am the messenger they are the doers, and I'm so grateful to be on this journey with them. Thank you.